by Abisha. Good morning, everyone. Today I'm presenting under the heading of Knock Knock, Who's There? So presenting Mr. X, a 30-year-old male who had presented to OPD with progressive worsening pain around bilateral hip joint. He has had this pain for almost 1 year, but it was worsening over the past 1 month. And the pain was more on the right side when compared to the left. And it was also restricting mobility at the hip joint, more restriction on the right side, and has developed bilateral painful swellings around the hip joint. This was not associated with any fever, weight, or appetite, no previous history of any trauma, no urinary disturbances, hematuria, or any history of pedal edema. Coming to the past history, he had a swelling around his left elbow at around 7 years of age, which was a hard swelling for which some surgery was done, but the details of which are not known. And he has also developed another similar swelling in the right elbow at around 20 years of age, which was not treated but spontaneously resolved. No history of any fractures in the past, no other significant comorbidities, and family history also, there was no significant family history. On examination, he was a normal built individual with a BMI of 22.1 with normal systemic examination. However, the local examination of hip joint had revealed multiple tender, firm to hard, lobulated masses which were palpable around the hip joint with restricted range of motion of the hip joint. But there was no warmth or erythema around the hip joint. So coming to the localization, this was a middle-aged gentleman who had come to us with painful swelling, progressive pain around the hip joint with examination revealing firm to hard lobulated masses. But the plane of the swelling exactly could not be made out. So coming to a localization, anatomically, it could either arise from the bone or from the hip joint. One more thing to think of, also subcutaneous origin. The pathological localization in this patient, considering that he's a 30-year-old male, could be a metabolic thing initially. Neoplastic is less likely because there are no constitutional symptoms. There is no history of any autoimmune features like any other joint pains, no rashes, no photosensitivity. And considering his age, degeneration is also less likely. So this was his X-ray of pelvis. Sorry that I have not put up a slide. Can anyone of you tell what exactly this is? Any thoughts here? Okay, I'll move on. So these are calcifications, predominantly periarticular in location around the bilateral hip joints. With this presentation, what can we think of? Calcification, periarticular location. These are heterotropic calcifications. The first differential we will think of is a tumoral calcinosis. The second thing is acute calcific periarthritis that can be there, but acute is less likely in this patient because of 1 year history, or a pseudo gout or a gout in a patient with a renal impairment. End-stage renal disease on hemodialysis can present like this. Any patient vascular diseases can present like this, or if there was a previous history of trauma, we can think of myositis ossificans, or a genetic problem, a fibrodysplasia ossificans, but the patient will have multiple other deformities as well. So to think of what substances can all deposit in our body, common things are calcium, phosphate, and uric acid. So we will see what our patient had. Coming to the basic investigations, his calcium was 9.4, which was normal, but phosphate was elevated. These were both fasting phosphate levels, which were elevated. Two levels had shown an elevated elevation. So this was a significant thing. But alphos was normal, creatinine was normal, ruling out end-stage renal disease, something like that in this patient. 25 hydroxy vitamin D levels was 32. But one thing, it was normal, but one thing to remember is this is not an activated vitamin D levels that we are measuring. The next thing is we did a bone turnover markers. The beta cross labs was normal. However, P1NP, which is a bone formation marker, was slightly elevated. And parathormone, it was also in the normal range. The next thing that we think of is FGF23, which was very high in this patient. I'll in some time. The other investigations to keep in mind was ferritin and CRP was elevated. So we have a patient with hyperphosphatemia with the normal calcium levels, normal parathormone, normal creatinine. So our differentials of acute calcific periarthritis, pseudo gout, end-stage renal disease, all other differentials are ruled out. So we have a patient with heterotropic ossification, and the most likely differential in this patient is a tumoral calcinosis. To understand, we know that a bone is formed of mineral, collagen, and organic matrix, and the bone is formed of calcium and phosphate. The organic matrix has osteoblast, clast, and osteocytes. The osteoblast secrete alk-phos, which is a marker of bone formation. The osteocyte is the intermediator which converts osteoblast to osteoclast, and this secretes FGF23, which is a very important thing in the regulation of calcium and phosphate metabolism. As we all know, these are common things. Calcium regulation, parathormone increases the calcium levels by increasing renal reabsorption, increasing calcium absorption, and also stimulating bone resorption. I would want to highlight phosphate regulation. Main thing is phosphate is absorbed even in the absence of vitamin D. The absorption is enhanced in the presence of vitamin D, and it reaches a 11 to 10 a.m. That is why even in fasting level, if phosphate is elevated, that is very, very significant. And FGF23 and parathormone are the two hormones that cause phosphaturia, leading to reduced phosphate levels. And vitamin D, how they act through vitamin D is they reduce the levels of vitamin D, thereby causing reduction in phosphate absorption. The other factors that can cause reduced reabsorption of phosphate is hypocalcemia, hypomagnesemia, and severe hypophosphatemia can in turn reduce the phosphate regulation. So in our patient, phosphate was high, vitamin D was normal, parathormone was normal, but FGF23 was very, very high. This shows that we know that if FGF23 is high, phosphate has to be excreted in urine. But our patient has high FGF23, but still phosphate remains high. That means there is a problem either with FGF23 or there is a mutation in the receptor that is involved in the post-transcriptional modification of vitamin 3, that is GALNT3 mutation, or there is a receptor mutation. So we proceeded with genetic testing in that patient, and it showed a GALNT3 mutation, and we diagnosed this patient as a tumoral calcinosis. So I would want to describe a few things on tumoral calcinosis. This was first described by Duret. Was named as progressive lipocalcinogranulomatosis, and this term was modified by Inclan. And it is a very rare genetic disorder. One third of the patients are familial. It mostly follows a autosomal recessive or a dominant inheritance, and typically presents as painless masses. This is where our patient differs. And it is more common in childhood, and most common location is hip joint. Other features include pulp calcification, short bulbous roots can be there. Most common mutations are GALNT3 and CLOT2. When the patient has pain, that signifies there is an underlying inflammation that is going on in this patient. So these are large extracapsular masses, typically have normal range of motion, but if it is restricted, the things we have to think of is there is a compression of neural structures, or there is an infection or an ulceration that is going on. Labs normally have increased phosphate levels, rest of the parameters being normal. They can also have a raised vitamin D levels. There are two types of primary tumoral calcinosis: normophosphatemic and hyperphosphatemic. Normophosphatemic has normal calcium and normal phosphate. Here arises a question. We saw that phosphate gets deposited. Then how is the normophosphatemia causing a tumoral calcinosis? The theories that have been proposed are very rich in phosphate. So even acute loads of phosphate or any rhabdomyolysis, any tumor lysis can all cause normophosphatemic tumoral calcinosis. The other causes being hemodialysis, hypoparathyroidism and all. There are multiple case series that have been published with the diagnosis of hyperphosphatemic tumoral calcinosis. This was one study published from our endocrine department. There are multiple studies on elbow, cervical spine, in the neck, and the scalp. So treatment, main medical management is restriction of phosphate in diet. The others can be phosphate binders like sevelamer. We can also use topical sodium thiosulfide. Acetazolamide has a phosphaturic action, which can also be used. We use surgical management only when there is pain, there is recurrent infection, ulceration, or functional impairment. But the problem with surgery is there is high risk of recurrence in these patients. This is a summary of whatever I have told. So in our patient, because ESR CRP was elevated, and as we saw P1NP was elevated, that shows that the patient has a high bone formation. So we gave bisphosphonate to silence the bone, and then added sevelamer and low phosphate diet. If the disease worsens, we may plan on a surgery because having a minimal functional impairment.
Thank you, Abisha. Any comments or questions? Can I ask Dr. Thomas if you'd like to add anything? We're happy to have you here.
It's a lot of very common case. We have some 15 cases. I don't know why, because it's seen in software engineers. 4 of them, because they sit for a longer time and the stress on the heat. So that is a postulate. Okay. Most of them are good.
So just bisphosphonates and acetazolamide and phosphate binders.
Bisphosphonate rarely beats.
Okay, sure. Thank you very much. Just a comment on the history. When you're saying hip pain, I would think of drug history for avascular necrosis. That's something that we often see in the medicine OPD. Differentiating between an inflammatory and a metabolic is another history that I might just ask right at the beginning. Sure. Thank you, Abisha. We'll move on to the next presentation, Lino's presentation on